past. And, there's always the question of what do you do when you get an abnormal screen and how do you manage that? So I hope that you guys can kind of just sit back and watch this and kind of get some good tips from it. I'm happy to share the slides afterwards, or any of the kind of documents and guidelines and policies that we'll talk about in this presentation. So just let Kelsey or myself know if there's something specific you guys are wanting. Okay, you guys see my slides moving okay? I know we've been doing Teams for forever, but I always feel like it's the first time every time.
It looks great.
Okay, thank you. So we're going to talk about the three different, kind of what I kind of consider the three different parts of newborn screening, which is the hearing screen, the metabolic screen, and the congenital heart screen. I'm also going to talk a little bit about car seat testing, and then I went ahead and added, as long as we have time to get through it, some of the medications, immunizations, RSV prophylaxis that kind of encompasses normal newborn care. There's a couple of good, I think, high yield items in those things as well. So I added those. Hopefully we'll have enough time to get through everything. So starting with the hearing screens, as someone who doesn't do outpatient pediatrics, I think I'm always surprised when I see how many babies and children there are out there that are going to have some sort of hearing loss. In just the general population, it's somewhere between 1 and 6 per thousand newborn infants will have some hearing loss. If we kind of extrapolate that down to patients or babies that are high risk, it's 1 to 6 per 100. So it's a good number of patients that we may see. So I think it was 1999, maybe 2000, the AAP recommended universal hearing screening for all newborns. And that really kind of led the way for most states to kind of enact some legislation, mandating programs, establishing federal funding for those programs. And so most hospitals now do newborn screening at discharge. The AAP actually recommends that the screening be done at least by a month of age, but I think it's generally done in that first hospitalization because that's where we're going to probably capture almost all newborns. But for the ones that are maybe not born in the hospital or born at birthing centers or other things, you have up to a month to kind of get that screening done. So in Texas and New Mexico, the program that kind of oversees hearing screening in those states is Early Hearing Detection and Intervention, or EHDI. And they really kind of track and trend all of the screenings that we do and kind of they also give us guidelines on who to screen and when to screen and how to do that. So we want to get the screening done by 1 month. And then the AAP also recommends that we have universal hearing loss detection by 3 months of age. So those of you that are doing these hearing screens or have patients that you're caring for that are getting hearing screens, you know that first screen is just a pass or a fail. And if they fail, is it a true fail or is it a false positive? They have to go on and get further testing. And so detecting the actual hearing loss isn't immediate. It does take some time. Often these kiddos get referred into the audiology clinic. So ideally we get them detected by 3 months of age. And then by 6 months of age, they hopefully are enrolled in interventional services. If they're needing any hearing devices, they have those in place and established. And so there's this goal set by the AAP. We call it the 1, 3, 6 month timeline. And we do really pretty well. I think in 2020, I think it was 97% of all babies born in the US had their hearing screen before 1 month of age. And there were over 6,000 babies diagnosed with hearing loss. So we do a pretty good job. And so there's some push to move this timeline back and shoot for a goal of a 1, 2, 3 month timeline. So again, the screening by 1 month, the detection now by 2 months, and intervention services and devices by 3 months. And, there's a couple of reasons to try to push this back. Obviously, earlier detection and earlier intervention is going to have better outcomes for these babies and children. And then there's also things just like testing is easier in smaller babies. They have longer sleep windows where you can get the testing done when they're quiet and calm. In older babies, sometimes if it's really difficult, they have to have sedation involved. And so it just is a little more complex and a little more risk to that as babies get older. Now, there are certain populations that's going to be difficult to do. So for us in the NICU, we often have babies that aren't able to get their hearing screens even by 3 months. And so that can be challenging. But most patients, we probably can kind of shoot for this earlier timeline. When we talk about causes and risk factors for hearing loss, we can kind of divide the causes in a couple of different ways. So one way to look at it, is it congenital or is it acquired? So congenital, generally, those are going to be a lot of our genetic hearing losses. Probably about 50% of hearing losses are going to be genetic. And so that's going to be a big chunk. I put plus or minus intrauterine infections because I think it kind of depends on how you qualify that. So things like CMV, with the, seeing Zika virus kind of come into the United States, we have babies that have hearing loss that have congenital Zika. And so that's another kind of portion of that congenital hearing loss. So then the second half of that would be acquired, again, infections. So postnatally acquired infections, things like meningitis, any trauma to the CNS, exposure to damaging noise levels. Of course, there's ototoxic drugs. Probably the one that we think most about is going to be gentamicin. And so those are other kind of the other group of hearing loss from a pre or post delivery timeline. The other way to divide them is, where is the site of the lesion? And so that would be sensory neural or conductive. So conductive hearing loss is going to involve kind of that outer or middle ear area, and then sensory neural is going to be more of your inner ear, the any issues with the auditory nerve, and then all the way through that central pathway through the brain and the brainstem. There's also ones that are going to be mixed. They're going to be kind of a combination, both of those. Probably the most of our congenital are going to be sensory neural. Our babies that are more kind of fall into high risk for hearing loss, NICU patients, things like that, that's more sensory neural generally. But those are kind of the two different ways of categorizing the causes. Risk factors. So as I said, CMV is a risk factor. And in the state of Texas, just last year, there was legislation passed that if babies who fail their newborn hearing screen should be screened for CMV. So we will screen and we'll rescreen once here in the NICU. If they fail both those screenings, we'll send off a CMV. It's really easy for us here because we can run those here in-house, which we haven't always been able to do. So we get the results back really, really quickly. But that is just some new legislation that was passed just last year. Other things that can put babies at risk for hearing loss: hyperbilirubinemia, prolonged mechanical ventilation, premature birth or low birth weight, prolonged NICU admissions, and low APGAR scores. So for us in the NICU, that pretty much encompasses almost everybody. But for those of you that are taking care of babies in a routine nursery, you're going to have CMV potentially. You may see, of course, hyperbilirubinemia, low APGARs, even some of the low birth weight babies. So you're going to have some of those patients that may be considered high risk as well. So and I should go back, about half of all babies actually aren't going to have any risk factors. So, we know what the risk factors are, but a good portion of our babies that are going to have hearing loss, about 50%, aren't going to have any risk factors. So when it comes to how do we test for them, there's really two recommended techniques. You're probably familiar with at least one, if not both of them. So one is the otoacoustic emissions test, or the OAE. This is what's probably most commonly used in newborn nurseries. And then the other technique is the auditory brainstem evoked response, or the ABR. This is what we would use for high-risk populations. So most NICU patients are going to have an ABR. They both identify hearing thresholds around 35 to 40 decibels and greater. So 35 to 40, you can kind of consider like a whisper, or how you would maybe talk in a library or someplace quiet like that. 60 decibels is what we kind of consider ordinary, like spoken conversation. So it kind of gives you an idea of what we're looking for. But that being said, these tests, they're screening tests. They're not perfect. They definitely can miss some mild hearing loss. And then they can also have some false positives for various reasons we'll talk about here in a second. So it's important that even if you have a newborn that has passed their newborn screen, they should have continued assessment and monitoring of their hearing throughout childhood. And so at those well child checks, I think it's built in at certain time intervals to recheck hearing. It'd be important to, talk to families about, what is the speech looking like? Do they have any concerns as their babies are going through their developmental milestones? That could be concerning for your hearing loss when you're seeing them in those well child visits. If a baby fails their initial screen, you can repeat it. There's guidelines that says you can do one single repeat. It doesn't have to be the next day. You can wait a few hours, especially if maybe the baby was fussy or there was a lot of ambient noise in the room and alarms going off or other babies crying. So if you can try to get them calm, you can feed them, you can get them to a quieter environment, and you can rescreen them one time prior to discharge from the hospital. If one or both ears are failed or didn't pass after the second screen, then you're going to want to refer them to audiology for further diagnostic evaluation. So we send ours to the Texas Tech Audiology Clinic, and they do a really great job of kind of getting those babies through that system and getting that diagnosis by 3 months of age if there is something there. I try to look and see, what's kind of the standard or what's a reasonable referral rate? How many failing patients should you be seeing that's acceptable? And most of the literature says somewhere around 2 to 4%. It does depend a little bit on which test you're doing. So, if you feel like you're seeing a lot of fails, you can kind of look and see, well, what's my referral rate? How many, what percentage of babies that we're screening are getting referred to audiology? We've done that here at UMC before in the NICU. Because these machines, they can be, there's some technique to doing them. There can be some user error. Do you have a good place and a good technique for getting the baby screened in a quiet, calm environment? And so if you have concerns, you're like, gosh, it just feels like we're referring more than we were. You can kind of look and see if you fall within that kind of acceptable referral rate. So just talking a little bit more about the test, the OAE looks at the function of the cochlear outer hair cell. So the cochlea is this kind of snail-shaped structure in the middle ear. So they call them outer hair cells, but they're really inside that cochlear in the middle ear. And what they do is they put that microphone probe into the canal, and they directly measure the outer hair cells and the cochlear function in response to that acoustic or sound stimulation. It's got pretty good sensitivity and specificity. It's probably the most widely used of the two tests because it's pretty cost effective, it's really quick, it's fairly easy. The one of the downsides to doing this test is you can imagine if there's any debris or any blockage in the ear canal, wax or anything like that, you can fail a test because of that and not because there's necessarily a hearing issue. So you just want to be cognizant of that. The second test, the ABR. So this is a direct measurement of the neural response to sound. So this is kind of look for those more sensory neural disorders. But it really it can pick up any, hearing issues through the outer ear, middle ear, and then all the way to the nervous system. But the OAE just does that outer and middle part. So this is the test that can be recommended for those high-risk infants. This is the test that we use in the NICU for all of our patients. As you can see, it's got also really, really good sensitivity and specificity. So we don't typically see as many you should see less false positives. But, a lot of our babies are immature. And so if the neurologic system is still a little bit immature, you can get false positives. So I do always tell our families if they've had 2 fails and they're going to be referred to audiology, don't panic. Go get go get more testing through the audiology clinic before we say, oh my gosh, my baby can't hear. Okay, and this is these are probes that go on the outside of the baby's head to pick up the signals. Okay, moving on to metabolic screens. So the newborn metabolic screens are done in every state. They're state mandated, and the goal is to identify infants with treatable conditions before they become symptomatic. So if you have older staff or staff that have been around a long time, they may refer to these tests as PKUs. We have several people that call them PKUs, and that's because when we first started doing these testings in the 1960s, we tested for one disorder, and that was PKU. And so you'll still hear people call that, oh, has the baby had their first PKU, or have we done the second PKU yet? And that's just kind of older terminology. In 2003, we were at 6 disorders. I was in my training during those years, so it was always these six diagnoses we were looking for. It was that way for quite some time as well. 2011, it went up to 26 disorders, and as time went on, and we learned more sophisticated testing techniques, we learned about more diagnoses, we understood them more. There were more treatments for things coming out. That number just kept climbing and climbing. And so today, I believe all states test for at least 29 disorders. I looked up to see for the patients that most of us are seeing. In Texas, it's 55 disorders plus the hearing screen and CCHD. So those are all kind of your basket of newborn screening. New Mexico tests for a few less. They do 45 disorders with their hearing and CCHD. As most of you guys know, it's a 2-screen system. And so doing 2 screens as opposed to just one really maximizes the effectiveness of testing. So it's a heel stick that the first test is usually at 24 to 48 hours of life, and then the repeat is at 1 to 2 weeks. Several reasons for doing it with 2 different screens. So there are some things that can make that first screen kind of falsely positive. So just stress from the delivery can make that first screen, the conditions that we're testing for, out of range. And so you would want to follow up the second screen, and oftentimes that one may be normal. If there's just like borderline results on the first screen, that second screen will either confirm that that is an abnormal screen or sometimes refute that, and you'll have a normal second screen as well. So there is some like a range of where you come back with that testing, if it's just borderline or if it's very abnormal. And then there's some cases that we may only detect in the second screen. There's a lot of physiologic changes in a newborn from prior to birth through the newborn period. And so if you screen too early, that baby may still be transitioning, and so you won't pick that up until that transition has happened afterwards. There's other things that make the first screen falsely positive. So, sick babies, babies on TPN, certain medications, babies that haven't been fed yet. And so having 2 screens really allows us to effectively screen every baby. As time has gone by and we're adding tests, these may continue to increase in the number of diagnoses that we're looking for. And so when we think about, what do we add? How do we know what to add? The WHO uses criteria that's kind of considered a gold standard when you're looking at a test. And is it a test that we should do? Is it a test that we should use for the general population? And we can kind of extrapolate that to what should be added to the newborn screen. And some questions that should be asked when we're looking at adding something are kind of listed on the screen here. So one, is it an important health problem? So does it affect enough people seriously enough to test everybody? Is it important? Do we understand the natural history of the condition? Do we know what we're looking at? Do we know what the outcome is going to be? Do we know what the timeline is? Is it recognizable in early stages? So ideally, there is a detectable preclinical phase, meaning we can test for it and pick it up before the symptoms start, because we want to prevent the symptoms. Is it a suitable test? Is the test acceptable to the population? The population generally is acceptable of a heel stick. That's a pretty mild, non-invasive, easy test to do. If the test was a liver biopsy, that's probably not going to be acceptable to the entire population that we biopsy every baby's liver, right? That makes sense. Intervals for tests for repeating the test should be established and determined. There should be an acceptable treatment. If we are testing for something that there isn't a treatment, or the treatment's not acceptable and people don't want to do it, maybe we shouldn't be testing for that. There should be facilities available, treatment should be available. Everyone should agree on who gets the test. And then the cost of case finding, the cost of doing the testing should be balanced with the benefits of the results that we get. And so, as time goes on, we may see more and more tests added. And so these are kind of the things that we would ask when we're looking at is something appropriate to be added to the newborn screen. Each state typically does a really, really good job of tracking their newborn screens. You know, I'm assuming it's the same way in New Mexico, but in Texas, of course, you know, they'll send you the newborn screen pretty quickly if there's something out of range or abnormal, and they do a great job of telling you exactly what to do. It may just be, if the second screen hasn't been sent, please send it. It may be you need to send some follow-up lab work, and they'll follow up with you to see what that lab work said. They may say this patient needs to be referred or discussed with a metabolic specialist, and they will send you the names of the metabolic specialists and how to contact them. They do a really great job of getting us the correct information and guiding us on what to do for those patients. So I think it's actually a really good system. Okay, moving on to CCHD screening. This is probably the test that we get the most phone calls about. So CCHD is critical congenital heart defect screening. A critical cardiac lesion is a heart lesion that generally neonates are going to require early intervention for survival. This came out, I believe, in 2010, 2011. The U.S. added the CCHD to the recommended uniform screening for newborns, and it's really, I think, a great test to do. If we look at infant mortality due to birth defects, somewhere upwards of 50% can be due to cardiac defects. And doing early screening can reduce deaths by about a third. So I think that's a really, really important thing to look at. But it is important to realize that this test does not pick up every single cardiac defect. It's most likely to pick up the 7 that are listed there on the screen. So it is the hypoplastic left heart, pulmonary atresia, and then what I was learned as the 5 T's of cyanotic heart disease. So tetralogy, total anomalous veins, transposition, tricuspid atresia, and truncus. So most likely to pick up those, doesn't pick up everything. It is a screen, so it can still miss things. But this, I think, is a really, really good test that is really important for our babies. Now, it doesn't take away from our other diagnostic strategies and our other things that we should be doing with our newborns in the nursery before discharge. We still want to rely on our physical exam, looking at the baby's blood pressures. Are they equal in the lower and upper extremities? Does the baby have any cyanosis? What does the heart sound like? Are there extra noise, extra sounds or murmurs? Are my pulses equal? It doesn't negate doing those things, but we do know that maybe only 50% of congenital heart defects are going to show up on a physical exam. And even in prenatal ultrasounds, we do detect a lot of cardiac defects on prenatal ultrasounds, but I'm sure all of you, if you've taken care of babies long enough at birth, have had those babies that had normal ultrasounds and have a major cardiac defect. It just wasn't picked up. So we kind of want to think of a CCHD as kind of layering it on these other things that we're already doing. Our prenatal ultrasounds, our physical exam, the CCHD is just another piece of evaluating babies for these severe cardiac defects. And hopefully all together, all 3 of those together will help us pick up everybody before they leave the hospital. So how do we do the test? So the infant should be at least 24 hours old and off oxygen. If you work at an institution where you are occasionally sending babies home before 24 hours of life, you just want to do it as close to that 24 hours of life mark before discharge as possible. All you need is a pulse ox, actually 2 pulse oxes, but that makes it a really good test. It's easy to do, it's non-invasive, it's painless, it's readily available. The pulse ox is going to measure, of course, the oxygen saturation of hemoglobin in the blood. And normal should be 95 to 100%. And we're testing in 2 extremities, which we'll talk about in just a second. And you should have less than a 3% difference in those 2 extremities. Infants with heart or lung issues may have lower readings. And so that's kind of the idea behind the test. And it's going to detect, hopefully, mild hypoxia that may not have other outward physical symptoms. So mild hypoxia without obvious cyanosis. That's the idea. when you're using your pulse ox probe, you want to put one on the infant's right hand, so that's our preductal side, and then one on either foot, that's our postductal side. The light emitter portion of the probe should be on the top of the hand or the foot, and then the photodetector goes just directly opposite, so it kind of wraps around the side of the foot, one on top and one on bottom. And you want to give it a few minutes and wait for the waveform to really stabilize. You may have to make sure the baby's calm, ideally not crying. If they're flailing about and moving the extremity, it may not pick up. So sometimes we kind of have to want to hold those extremities still. Sometimes we kind of cover them with a blanket if we're still having trouble getting the waveform to read. But remember, the way that a pulse ox works is that it's not an instantaneous reading. It's kind of an average of readings over a few seconds. So you want to give it a little bit of time to make sure you're getting enough time to get that average and that the waveform is nice and steady. And again, remember, it's not going to pick up every form of congenital heart disease. So there's multiple different algorithms or structures of the algorithms and how they look for cardiac screens. I really like this one. I like the way that it's set up. And so at the top, your baby in the well nursery, at least 24 hours of age or just right before discharge, you're going to do their screen. If they're on the left side in the red boxes, if either the right hand or the foot is less than 90, that is a fail. That's an automatic fail, and that's a positive screen. If the pulse ox is greater than 90 but less than 95, that's I call it an indeterminate or not a pass, or there's greater than 3% difference in the two extremities. If you fall into that yellow kind of intermediate, you can a testing result, you can repeat the screen, and you can repeat it within after an hour. It doesn't have to be like the next day. You don't have to keep the baby another day. You can repeat it in an hour. You can actually do that twice. Okay. If you've repeated it twice and you're getting the same read, you have a failed or positive screen. Okay. Less than 95 or more than 3% difference in the two extremities. So what's a pass? A pass is the right hand and foot are at least 95%, and you have less than a 3% difference. So you can have 95 and 98. You can have 98 and 100. But if you have 95 and 100, technically they're both above 95, but you have more than a 3% difference. So that would be a fail, or at least an indeterminate, and you can repeat it. So if you have done all your testing and you end up with a positive screen, which is a fail, what do we do next? This is where we get called a lot. So that baby needs to be evaluated by a physician, and they need a diagnostic echo that's read by a pediatric cardiologist. And this is where it gets difficult because, a lot of our community centers don't have that capability, and they're in the hospital. And so, we get phone calls. Can the baby just follow up outpatient with a cardiologist? Can I send them to the clinic? Do they have to come to Lubbock to the NICU and get the screening done? And the answer is yes, because if you think about what we're screening for, even a baby that looks really, really good, that's not something that we want to miss, and time is not always our friend. So these babies do need to be sent to a center that can get this testing done if you can't do it at your home hospital. Now, that being said, when I get these phone calls a lot, they'll say, "Hey, I have this baby in the newborn. They failed their CCHD, and now they're just desatting, and I had to put them on oxygen." And I think that's another interesting part of this test. The baby didn't start desatting. The baby probably was having that mild hypoxia, but clinically looked great, didn't have any work of breathing, wasn't cyanotic, was eating fine, but was probably had those SATs in maybe the upper to mid 80s. And when you put them on the pulse ox for their testing, well, you know that they have some mild desaturations. So a lot of times in those situations, it's not a cardiac issue, it's a respiratory issue. Maybe the kid's got some mild TTN. Maybe there was some meconium or amniotic fluid that was aspirated and the baby's got a little bit of pulmonary inflammation, things like that. So besides ruling out the cardiac defect, especially if that is negative, you want to evaluate that baby for any respiratory issues. You want to evaluate them for any infectious issues. Maybe the baby's got a little bit of pulmonary hypertension and just had a delayed transition. We see that a lot. And honestly, because those things are so much more common than these major cardiac defects, almost all of the babies that we get have one of those diagnoses and not necessarily a cardiac diagnosis. So they may not be as common as these other respiratory diagnoses, but obviously the risk of missing them is much higher. So the CCHD screen kind of will pick up some of those and other issues as well that maybe aren't as noticeable on physical exam. Okay, moving on to car seat testing. In 1991, the AAP recommended all newborns less than 37 weeks or less than 2,500 grams receive a pre-discharge infant car seat challenge. The reason for this is babies that do great laying supine may not have any respiratory issues, but when we put them in that semi-reclined position of a car seat, they can have some cardiorespiratory instability, and they may not have as much physiologic maturity to maintain their airway or to maintain good respiratory effort. Changes in that position in newborns can cause some inability to maintain their stability. And it's important to know that because babies that have frequent cardiorespiratory events or intermittent hypoxia can have adverse effects later on. It can affect their neurodevelopment. It can affect their psychosocial behavior and their academic achievement. And remember, it's that semi-reclined position. It's not just in a car seat. It's pretty much in anything else you put a baby in, a swing, a bouncy seat. Sometimes how we hold them, we're holding them in that semi-reclined position. And so it's not just the time that they may spend in a car seat, but it's all the other times that they're in that same position that they could be having that instability. There are other babies that we need to think about that would also, you'd want to do a car seat test before they go home. Probably the one that most of you are going to see most often is going to be your Down syndrome babies. Remember, Down syndrome babies typically have just overall lower tone. And when we think about muscle tone, you have to remember there's muscle tone in our neck and airway that help us maintain that respiratory stability. So you definitely want to be sure your Down syndrome babies get a car seat test before they go home. Other things that we see more in the NICU, not so much in the newborn nursery, but other hypotonia syndromes, babies with neurologic disorders, airway disorders like Pierre-Robin. And then we also, if we have a baby that is going to go home on oxygen, maybe they're a preemie with significant chronic lung disease and they need a little bit of oxygen for discharge, we're going to put those babies in a car seat. Post-cardiac surgery, those kiddos need car seats before they go home. So how do we do the testing? So you, again, want to do it at 24 hours of life. That's always, for most of our testing, is if you haven't noticed the pattern, everything you want your baby to be at least 24 hours of life. If they're going home without oxygen, you want to do it when they're off oxygen. Again, you want to put that pulse ox on the right hand. That's a theme as well. And ideally, you want to do the car seat test in the baby's own personal car seat that they're going to go home in. You want to be sure that they are the restraints and the straps are done per manufacturer guidelines, that it's at the right angle for vehicle use. So you want to mimic the same angle that it's going to be sitting in the car in. And usually that's all in the manufacturer guidelines. Ideally, we want to do it a minimum of 90 to 120 minutes. Some places will do, whatever the family's duration of travel is going to be. I think you have to be careful with that. If you live 5 minutes away, you probably don't just want to do 5 minutes because they may be sitting in it for longer at other places. Most babies are going to be feeding every 3 hours, so no one's probably going to be driving more than 3 hours. But it's really hard to keep a baby in a car seat for 3 hours. So we do 120 minutes. But really, you want to just be sure that your hospital, your institution has their own policy and protocol of how you want to do that and for how long. If the other thing, let me go to that. Yeah, okay. So the thing that's tricky about car seat testing is that the AAP doesn't really give us parameters of well, what are we monitoring? What specific vitals and what things specifically should we be monitor, and what constitutes a failure? They're real vague. And so that's why I say it's important that the hospital has a policy and a guideline of how they want to do it. Things that can be recommended to look for, obviously the baby has apnea, if they're bradycardic, if they're hypoxic in a car seat, those are pretty easy. Do they have increased work of breathing, and how do we define that? Is it, how fast are they breathing? So the little snippet there on the right is just a piece from our car seat policy at UMC. You can kind of see at the top, like I said, we do 2 hours or 120 minutes, and we look at these 6 criteria every 15 minutes, and the nursing staff documents it. So respiratory rate, heart rate, saturations, what's their effort, what's their skin color. If they're dusky in the car seat, that's probably not something that we want to call a pass. And what's their activity? If and good documentation is really, really your friend here, because if I have a baby who's in a car seat and they're tachypnic the whole time, and I'm like, oh my gosh, this baby's breathing way too fast, and I go talk to the nurse and she's like, well, the baby was crying. Okay, well, that's a little bit different. So that's why activity is in there. What else is going on? Ideally, the babies are calm. And so we also have in our car seat, like when should you feed them? We try to do a feed, at least 30 minutes before, but you don't want to put them in the car seat right before a feeding is due and they're going to be hungry and irritable. If the baby's going home with oxygen, we want to be sure that they get a car seat with the oxygen. And then at the bottom there is kind of the things that we would consider a fail. So we have some heart rate parameters based on the baby's postmenstrual age, what we define as apnea, persistent labored respirations greater than 60, and then again, if the baby is dusky or desatting. So those are kind of the things that we document and look for in our car seat tests. If a baby fails, well, what do we do? Well, there may be some diagnostic evaluations that need to be done. Has the baby had a chest x-ray? Do they need an echo? What else is going on? Do we need to be looking for other diagnoses that could be causing them to fail? Do they need oxygen? So we have babies with chronic lung disease or other respiratory issues that are prolonging their stay, and maybe just a little bit of oxygen would keep their stability in a car seat. And so sometimes we end up discharging babies with oxygen. The vast majority of the time, they just need more time. And the way that I talk to parents about this is, if your baby is struggling just being put in a car seat, it just means they have no reserve. Their physiologic cardiorespiratory stability is so fragile that just putting them in this position makes them decompensate. And it just means they're probably maturity-wise not ready to go home. In the newborn nursery, maybe they still have a little bit of transitioning from fetal life to neonatal life. Maybe they just need some more time to transition. Maybe there's still a little bit of elevated pulmonary vascular resistance, or maybe that PDA is still a little bit open and they just need a little bit more time. So one of the things that you want to be sure you have in your hospital policy is, what do you do with these failed tests? When do you repeat them? So for us, we will repeat the test in 24 to 48 hours. If they fail again, then we wait a week. Now, keep in mind, that's in the NICU. You can't keep a baby in the nursery that long. But, if you have a baby that's persistently failing, you may need to send them to a NICU or a hospital that can do a more detailed evaluation and diagnostic testing to see why they're failing. The other thing that is an option, and we really kind of try to steer away from it, is a car bed. So a car bed is exactly what it sounds like. It's like a little bassinet almost that's made to be strapped into the car that the baby can lay supine in, and it kind of gets you away from that semi-reclined position. Those are challenging, and they are talked about in the AAP, but remember, like I said before, it's not just the car seat that the baby's in that position. So if you send a baby home in a car bed, are we going to be able to ensure that that family understands not to put them in a bouncy seat, not to put them in a swing? And then the goal would be to get them out of the car bed and back into a car seat as quickly as possible. The car beds are probably not going to be as safe in a vehicle as a car seat would. And so you have to have a way to do another test, and that's going to have to be in an outpatient basis in a clinic. And is there a clinic that has the time and resources to do an appropriate car seat test to get them out of that car bed? So those are out there. We really try to steer away from them and just give babies more time. We have never had a baby, and now it may take some time, but we've never had a baby who doesn't end up passing their car seat. So, we try to wait it out as much as possible and make sure that we've, crossed all of our T's and dotted all of our I's and making sure there's not something else going on. Now, I will say there's a lot of talk right now out in the communities of newborn and NICU care about doing car seats. Even though the AAP still recommends them, there's not a lot of great data to support doing them. And there actually are some places that don't do them. We still do here in Lubbock, just because it's still recommended. But I will tell you that I'll put the little caveat out there that the data is not always super super strong, and so there are some places who don't do that. Okay, I think we're doing okay on time. I want to talk about these newborn medications. I don't know at where you guys are at if you're seeing this, but for sure over the last couple years here at UMC, we're definitely having more and more families coming in that are declining the newborn medications. And so I thought this was a good opportunity to kind of talk about it, about maybe why we're seeing more of that, to talk about why we give them, make sure that we as the healthcare providers fully understand what they're for. That helps us when we have those conversations with our families. So we'll talk about erythromycin and vitamin K, as well as hepatitis B. As we go through these slides, you'll see some of them there's stronger support for than others, and I sometimes use that to my advantage. There's one that I always try to be sure all of my babies get, and I will barter, if you want to use that word, with families. Okay, how about we don't do this one or these two, but let's just do this one. Can we just do this one? And if all else fails, I usually have pretty good success with that. So, starting with erythromycin eye ointment. Erythromycin is used to prevent neonatal conjunctivitis, or the fancy term is ophthalmia neonatorum, or neonatal ophthalmia. And really, that's just a fancy term for saying neonatal conjunctivitis in the first 4 weeks of life. It is made to treat conjunctivitis from gonorrhea. Now, one of the problems with erythromycin is we really don't see as much gonorrhea. That's not the leading cause anymore. It's really chlamydia. And erythromycin doesn't really treat chlamydia conjunctivitis. So that's one of the issues. But I think it's also important to keep in mind, like, this erythromycin isn't our primary strategy for preventing neonatal conjunctivitis. Really, our primary strategy is in the antepartum period, identifying moms who have these infections and treating them appropriately so that we don't expose the baby to these infections during birth. Right now, though, erythromycin is mandated in most states. It doesn't mean that you're breaking the law if you don't give it. Parents can opt out, but it would be considered part of standard of care otherwise. It's relatively low risk. I mean, the risk really is maybe some mild temporary eye irritation from the medication, but it's pretty rare. The other thing that's, I think, important, and sometimes this helps parents be okay with giving these meds, is that it doesn't have to be as soon as the baby's born. That mom can skin to skin. She can do her first breastfeeding. She has time to bond. So really, what most the research will say is you can wait an hour. And the hour mark is just because that's what's been studied. We don't necessarily know that if you wait longer than that, there's a problem. That's just what's been studied in the literature. So that's what most people will quote. I did look in Texas law says it should be done within 2 hours. New Mexico just says as soon as possible. But I have had parents say, oh, I'm just worried they're not going to be able to see to breastfeed, or they're not going to be able to see me, and they're not going to bond. And I think that the eye goop's going to affect their vision. I think most of us know they don't really see very well regardless. But that's something that you can offer to those families if that is their concern. Now, the reason that this is important and that we do want to be sure that we are protecting babies is 30 to 50% of babies that get exposed to these infections during labor will develop this conjunctivitis, and it's very rapidly progressive. So if we wait until the baby has symptoms, like if the family's like, oh, I don't want to do it, well, if they have signs of it, then we'll treat it. Well, the problem is it's pretty rapidly progressive, and you get to permanent damage to the cornea and blindness relatively quickly. About 3% will have blindness if it's not treated timely. And the treatment is not, once you have it, the treatment is not the erythromycin eye ointment. It's typically IV antibiotics. It's prolonged hospitalization. So the eye ointment is more of a preventative. If we actually have to treat the infection, it's much more involved and detailed. Now, I will say for many, many years, the AAP has said they do support ongoing reevaluation of whether or not this is necessary. And I think that's because the epidemiology of what bacteria we're seeing, chlamydia, E. coli, erythromycin is not going to be protective of those infections. But as it stands right now, it is still mandated in most states. Okay. On to the big one, as I call it, vitamin K. So vitamin K is given to babies in the newborn period to prevent vitamin K deficiency related bleeding. We used to call this hemorrhagic disease of the newborn. So those terms are sometimes used interchangeably. Technically, I think we've tried to move towards vitamin K deficiency bleeding because we know now that hemorrhagic disease of the newborn is caused from vitamin K deficiency. Vitamin K is essential for the synthesis and activation of several coagulation factors that keeps us in a nice homeostasis between bleeding and clotting. And this bleeding from vitamin K deficiency is much, much more common in newborns than adults and older children. And that's because it really only takes a small amount of vitamin K for those coagulation factors to work well in humans. And it's found pretty widely in most of the foods that we would eat as older children and adults. It's also made by gut flora, and adults and children, if we're otherwise healthy, we typically have a really nice healthy gut flora. And so if you have an adult or a child that has vitamin K deficiency bleeding, it's going to be usually associated with one of a couple things. Really profound inadequate nutrition or dietary intake. They're just not eating anything for whatever reason. Intestinal disorders, so enteritis, cystic fibrosis. Maybe they've had significant intestinal resection. They don't have the same amount of intestine. Malabsorption syndromes. And then to a lesser extent, maybe a decreased production by that normal flora. So maybe you have an adult that has been on a prolonged broad antibiotics, and so they've kind of wiped out their gut flora. They may be at risk, but for the most part, this is a newborn issue, and that's because newborns are going to be deficient both endogenously in what our body is able to make itself, and exogenously, meaning what those newborns take in. So endogenously, newborns don't have a mature, sufficient amount of intestinal bacterial flora at birth to synthesize and absorb vitamin K. That takes time. So that's not going to allow them to make their own vitamin K or their own bacteria to make their own vitamin K. And then unfortunately, vitamin K has very, very poor placental transfer from the mom to the baby. So I've had a family that said, oh, mom, she took lots of vitamin K. She ate all the foods that were high in vitamin K so that the baby would get it. So we don't have to give vitamin K. Well, it just unfortunately doesn't work that way. Doesn't go through the placenta well. It also unfortunately does not go through the breast milk. There's extremely low concentrations of vitamin K in breast milk. So again, mom's diet isn't going to help us in this situation. Now, formula does have added vitamin K, but even exclusively formula-fed newborns will have low vitamin K levels for several days. It takes time for that vitamin K level to be sufficient. And so those babies are still at risk. And really, up until 4 to 6 weeks, when babies start ingesting more foods and have time to develop a mature, sufficient bacterial colonization of the gut, all babies are going to be at risk. So we are not just talking about a couple of days at risk. We are talking about, 4 to 6 weeks, several months. Luckily, the treatment is what we consider very easy, right? One single IM dose of 0.5 to 1 milligram, depending on the weight. And again, it doesn't have to be right away, just within 6 hours. And the AAP has been recommending this since 1960. So we have been doing this for a very, very long time. And millions of babies have been given vitamin K. I think that's important. Families often will ask about oral. Can we just do oral? There's various reasons we'll talk about. What is important to know about oral vitamin K is that it's 100% less efficacious, especially in that late onset vitamin K deficiency bleeding, that later into the several months of life. And actually, one of the suggestions of why we are seeing an increase in vitamin K deficient bleeding in newborns is touted to be because of more use of oral and less of the IM, in addition to just parent refusal in general. We have more parents refusing and more parents giving oral, and we're seeing more vitamin K deficiency bleeding. The other thing to remember about oral vitamin K is that oral drug absorption is not always consistent, and it's not 1 or 2 doses. It's multiple doses through the first 2 to 3 months of life. So I'm a healthcare provider. I feel very strongly about, how we take care of our babies. I'm a terrible patient when it comes to taking all of my medication, taking it on time, getting my kids to take it on time. It's hard. And so now you have a family with a brand new baby at home, which is very stressful, and you're tired and you're exhausted. And we want to be sure that they are getting these doses at an appropriate time and taking every one and not missing any. It's more difficult than you think. In the oral route, like I said, it's recommended to continue until 3 months of age. So it's not just a dose or two. So when we talk about vitamin K deficiency bleeding, there's a couple of different categories, and it's related to the time of onset. So there's early onset, classic, and late. Early onset is usually within the first 24 hours of life. And this is a little bit different because this is usually due to maternal medications that affect vitamin K metabolism. So moms that are on certain anticonvulsants, TB meds, there's some warfarin, antibiotics, cephalosporins are notorious. So you need to be really careful if you have a mom that are on those types of medications, either, be sure that if they can be switched to something else, or, to be sure that that baby gets their vitamin K quickly. Bleeding from early onset can be something like skin bruising, intra-abdominal bleeding, but most commonly is intracranial bleeding. And that is the bleeding that we are just terrified that we're going to see in these babies because they can have such severe neurologic sequelae or death from that intracranial bleeding. Classic is 2 days to a week. This is often what we would see for babies that don't get vitamin K, that are exclusively breastfed or don't eat well. A good portion of them are just going to be idiopathic. And again, these are babies that don't get their vitamin K. If they get bleeding because they didn't take their vitamin K, this is kind of where they fall and why. This tends to be the not as severe because although you can have bleeding from all those sites that you see there, most commonly for these babies, it's the GI tract. These would also be the babies that you hear about having bleeding from the umbilical cord, or they have a much, much higher rate of post-circumcision bleeding. So your babies that have extensive circumcision bleeding, if they didn't get vitamin K, you may see that. So I will tell you, actually, I have had a family who didn't want vitamin K, and when I told them I wasn't going to be able to do their baby's circumcision, they changed their mind. So sometimes that works too. And then late onset is that one that I think is often the scariest because it can take so long after birth. It can also be idiopathic. It's often more at risk for exclusively breastfed infants. But these babies can also be because of other underlying diseases or medical issues. So liver dysfunction, if you have a baby with neonatal hepatitis or biliary atresia, sometimes in the kiddos with severe liver dysfunction, we're actually going to give them another dose of vitamin K. If you have a baby with intestinal malabsorption syndrome or issues, short gut, things like that, we want to be careful with those kids. And again, these kiddos most commonly are going to have intracranial bleeding, 30 to 60% of them. So when I think about parental refusal with vitamin K, I kind of put them into a couple different categories. So one is just their belief system. So sometimes it's just they don't think it's needed or they don't really understand, or they just want everything to be very, very natural. So, we have a large Mennonite community in our area, and they are just some of the most lovely families to take care of, but they often initially request none of those medications. And when I sit down with them and I'm like, well, tell me what you know about vitamin K, tell me what you're thinking, they'll just tell me, I don't really know what it's for. And so we'll kind of talk about it, and they are immediately like, oh, yes, please. That's totally fine with vitamin K. So they don't have the information. So sometimes It's just as simple as, talking them through it. The other one that we get a lot, and that sometimes is more challenging, is what I kind of classify as infant welfare. So you'll have parents bring you or talk to you about, well, vitamin K causes cancer. So there was one study in 1999 that had this kind of unexpected association of vitamin K with childhood cancer. Well, since 1999, 35-ish years ago, there have been multiple, much larger, much more well done scientific studies that have completely refuted this association. Completely refuted it. So that one study is just considered not to be valid. And like I said, we've been doing this since 1960, and there are millions of children that have gotten vitamin K, and there is no association with childhood cancer. The other one is pain. I don't want them to have pain from the injection. These are the families that often ask about oral. Other ones we hear is they're concerned about preservatives or what else is in the vitamin K. So there's a couple different things that get brought up. Benzyl alcohol. Again, there's no evidence that it causes any toxicity. Benzyl alcohol is actually like naturally produced by lots of plants. It's in fruits, it's in teas. It's found in a lot of essential oils that sometimes are in the room when you're talking to a family. So benzyl alcohol there is not an issue with that. Some are worried about mercury. There is no mercury in vitamin K. Some are worried about the tiny hundredth of a tenth of aluminum that's in there. Those things are not going to cause any issues with getting vitamin K. The other one that's a big challenge, that's probably one of the most common ones, is they'll bring up the black box warning. So there is a black box warning of vitamin K causing severe life-threatening allergic reaction and death. Now, what's important to know is that that's not in the black box warning, is that is in patients that received very, very large doses very, very rapidly through an IV. That is obviously not what we're getting. There are 4 million births a year in the United States. There have been no reports of anaphylaxis from newborn IM vitamin K. And then, of course, there's just always the outside influencing factors. Friends, celebrities, even other healthcare professionals who will say you shouldn't receive vitamin K for X, Y, and Z. So I think it's important to understand a family's point of view. What are their concerns? Why are they not wanting vitamin K? And then it's our job as their primary care physicians or their healthcare physicians at that time to talk through them with that. There are some resources that I think are really helpful. So this is from the CDC website. It's just like a parent kind of handout or fact sheet that has a lot of the benefits about vitamin K, why we do it. It addresses a lot of the concerns. So that is available. And then this is also from the CDC. It's a supplemental information sheet. I actually have this in my office. And if I'm going to talk to a family, I just look at it really quickly because it really is super high yield. It's very well worded. It really just kind of reminds you of all the little points that you're most likely going to either hear concerns about from families or gives you the little talking points to go and talk to them. So I have this in my office. I always look at it, and I think it's really, really, really good. And so if nothing else, this is a great resource if you're going to talk to a family who is requesting not to get vitamin K. Okay, we only have a few minutes, so I'm just going to go through real quickly. Hepatitis B. If you have a hepatitis B positive mother, remember your baby within 12 hours should get hepatitis B, C, and HBIG. If the baby is small, under 2 kilos, they will still need 3 more doses of vitamin K. So, of hepatitis. So typically most babies only need 3 total. If you have a small baby who gets it at birth because mom is positive, they need 3 additional doses. If mom's status is unknown, you still want to go ahead and give hepatitis B within the first 12 hours, but you do have a little bit of time to get mom's testing back before you give HBIG. If it's a bigger baby, 2 kilos or more, you have a week. If it's, again, that small baby, you want to go ahead and you want to get that HBIG by 12 hours if you don't have mom's status back within 12 hours or mom is positive. And then my last slide, just one little reminder about Beyfortus, which is the new RC monoclonal antibody. The one that we had in the past was Synagis. This is really, really great. I really want to tout it because this is for all babies who are less than 8 months of age, born during or before their first RSV season. The guideline says you should give it at hospital discharge or at the first office visit within a week. So, if your institution hasn't decided how they want to do this, I think it's a great policy to talk about. Are we going to do this at discharge? Are we going to push this to the pediatrician and family practice physicians who are seeing these kids at their first visit? But it's great because as opposed to Synagis that needed one shot every month for your high-risk babies, it's a one-time dosing per season, and it's for every single baby. Now, if you have a baby that is older than 8 months, if they are high risk, you can also give them Beyfortus. Okay, that is all I have. 1 minute over, but I think if I'm able to stay, if anybody has any questions, I'm happy to try to answer for you. I hope that was informative for you guys and helpful. I'm just going to get up here and see if there's anything in the chat. Awesome. We can get out some of those vitamin K information sheets. I'll have Kelsey send those out. All right. If there are no questions, thank you guys for all listening. We'll get the slides out that have all of the information in. If you need anything else, please reach out to her and we'll make sure we get everything to you guys.